Now, 12:02. Getting started. I want to welcome you all to the Women's Health Seminar. We're getting close to the close for this year, but they've been so exciting. And today, we're going to be taking a look at sex differences in acute coronary syndromes. Our speaker is Dr. Karin Humphries. She's an associate professor in the Faculty of Medicine at the University of British Columbia and holds the UBC Heart and Stroke Foundation Professorship in Women's Cardiovascular Health. She has a doctoral degree in epidemiology, a background in biochemistry, kinesiology, and experimental pathology, but her primary research focus is on sex and gender differences in the diagnosis, treatment, and outcomes in subjects with coronary artery disease. Dr. Humphries is currently investigating the impact of sex-specific cut points for high-sensitivity cardiac troponin on the treatment and outcomes of women presenting to the emergency department with chest pain. Dr. Humphries is also the director of the cardiovascular program, ICV Health, at the Center for Health Evaluation and Outcomes Sciences, CHAOS. In this role, she is committed to improving health outcomes for British Columbians at risk for or living with cardiovascular disease by generating and applying new evidence to improve the delivery of cardiovascular care in the province. A fun fact is that Dr. Humphries is an avid baker of sourdough bread. So welcome all. So good to have you here.
Thank you so much. Thank you. And thank you for the privilege of being here today and to participate in the Women's Health Seminar Series. I've heard a lot of very good things about it. All right, let's get started. So as you know, I'm going to talk about sex differences. It's a passion of mine. And I'm going to give you a little bit of background, and then I want to flip right into the trial that we're just about to launch because I think it'll be of interest to you. So let's go back 65, maybe 70 years ago. If you wanted to find some patient material on women and heart disease, this is about as good as it got. This is from the American Heart Association, and it's entitled, How to Help Your Husband Recover from His Heart Attack. Seriously, that was the extent of our focus on women and heart disease. Now, we've made progress, but much, much more needs to be done. And this is actually a vignette that is quite true. It was a 40-something woman, happens to be called Esther. And you know, like many women, her primary health concern was breast cancer. I completely understand why. So when she's rushing through Pearson Airport a couple of years ago and she's very, very short of breath, the furthest thing from her mind was that she had a heart attack. And indeed, when she was worked up after the fact, that shortness of breath, which is a common presentation in women, proved to have been a heart attack. For me, this whole field really began to change, I think, in 2001. And that is when the Institute of Medicine published this document here. And you can see the title, Exploring the Biological Contributions to Human Health, subtitle, Does Sex Matter? And I've pulled out a few quotes here. And what it is essentially saying is, to really do high-quality science, we absolutely need to pay attention to sex. It is beyond dispute. This is critically important. So what impact has that had, and what has our timeline looked like in terms of moving us from viewing heart disease as a man's disease to understanding that women are also at risk? And indeed, in North America and around the world, more women will die of cardiovascular disease in its broadest context, by the way, so that includes cerebrovascular disease, than anything else. So it is a critically important issue for women. So if we go back to the 1990s, the Americans really were one of the first out of the gate. The National Institutes for Health actually opened up an office of research on women's health. So that was a very positive start. The National Institutes of Health actually passed some legislation called the Revitalization Act, where they absolutely insisted that if the NIH was going to fund a randomized controlled trial, you had to include women unless there was a compelling reason not to. So a compelling reason not to might be if you did a trial on prostate cancer. But in the field of cardiovascular disease, I'd love to see anybody come up with a reason why you should not include women in a randomized controlled trial. As Canadians, we're polite, so we didn't pass any legislation. We encouraged the inclusion of women in clinical trials. That was in 1997. In 2000, really pivotal year, and I think it's still the only institute in the world, the Institute of Gender and Health was established by CIHR, which is such a critically important organization. And then, of course, as I've already alluded to, the Institute of Medicine publication in 2001. Starting in 2010, CIHR started insisting that if you applied for funding to CIHR, you had to address whether or not you were incorporating sex and gender. Now, that started off, as many of you probably know, as simply a tick box. We have evolved from that. I just came back from a peer review session where we now actually check that you did more than just check the tick mark, that you actually are incorporating sex and gender if possible in your grant, that it's part of your analytical plan, that it's in your background, that you've really incorporated it in a meaningful way. And Heart and Stroke has now done the same thing. So again, I think we have made progress. However, there are still major issues that are an impediment to us advancing this science. This is a recent publication from the Canadian Journal of Cardiology, and what you see here is the mean percent of females that have been enrolled now in cardiovascular trials over this timeline. So going back to 1986 and ending just 4 years ago. So we can see a bit of an increase, but even by 2015, we haven't even hit 35%. So the appropriate question might be, what should we be hitting? And I would argue we should be enrolling between 45 and 55% women. Now, why am I giving you that range, and why have I chosen those numbers? My argument for determining how many women we should enroll is, I think you should enroll women proportionate to how much disease is in the population. So let me show you what that looks like. So here you see the percent of women in trials in the black bar, and in the hatched bar, the proportion of women in the population who actually have this disease. And so you see I've broken it out by coronary artery disease, non-coronary or vascular, so this could be peripheral vascular disease, this could be valvular disease, women get a lot of valvular disease, heart failure and arrhythmia, and you can see across the board, the black bar never equals the hatched bar. So we are not enrolling enough women to represent what they're experiencing in the population and, frankly, to power our studies so that we can actually draw definitive conclusions. Nevertheless, there have been some important discoveries, and I want to just focus on one before I get into my trial, and that is we now understand that a significant proportion of women can present with coronary artery disease that is not the classic coronary artery disease. Now, I'm a lot older than the rest of you in this room, but probably even the people in this room, when you learned about coronary artery disease, the focus was on the epicardial vessels, so the large vessels on the outside of the heart that actually feed the heart. So the left anterior descending, the right coronary, the circumflex, etc. It's not that that is an invalid image. It is indeed true. Let me see if I can use this mouse. Yeah. If you look at this diagram here, this is our classic understanding of coronary artery disease. You can see in the yellow this buildup of plaque. Now, as that builds up and the endothelial covering on that plaque gets thinner, so a vulnerable cap, if it ruptures, you get a thrombosis, and that's our classic heart attack. Now, women can absolutely present this way. I don't want to leave you with the image that women have completely different disease. However, what we do now understand is that women are more likely to have small coronary artery network disease, microvascular disease. Up to 40% of women will present this way. So what that means is now in these really small vessels, which by the way you cannot see with a coronary angiogram, which is our gold standard test for diagnosing coronary artery disease, you will still get a little bit of buildup of plaques. You can see the little bit of yellow here, but notice how different it is from here. It's much harder to see. It's much more diffuse. And actually, the disease also affects the entire vessel wall. So you can have spasms, or you can have inappropriate relaxation, which I'm sure you can appreciate would then affect the flow of the blood. So this is microvascular coronary disease. Now, why is this an issue? Because as I alluded to, we like to use the coronary angiogram as our gold standard test, but it cannot see that. Now, there is a way of getting around that. So on the left here, you can see the angiogram. Let me just direct you here. This is the left anterior descending. And I think most of us, certainly me, because I'm not a cardiologist, let alone trained to look at angiograms, I would think that this LAD is quite normal. Now, if you inject acetylcholine and the vessel is truly normal, it should actually relax. But I think you can see, if you move to panel B, how it is actually narrowed. This is not an appropriate response, and this is a flag that actually, while you can't see the microvasculature, you actually have microvascular disease. It is a relatively simple test, but it is rarely done. So this is what you'd have to do in the cath lab in order to diagnose coronary the microvascular disease. So if you had a woman presenting with ischemic symptoms, you went in and you saw this, it would be nice if you did the extra step, injected the acetylcholine to see if perhaps this individual has microvascular disease, because it can also lead to myocardial ischemia, which would then represent as acute coronary syndrome. All right. So with that as a bit of background, I really want to move into talking to you about the trial that we're going to do. We've named it CodeMi. So it looks at high sensitivity cardiac troponin. For those of you in the audience who may not know, cardiac troponin is a biomarker that we rely on in the diagnosis of a myocardial injury or myocardial infarction. So this is a multi-center, stepped wedge, cluster randomized control trial that we are fortunate to have funded by CIHR just over a year ago. The overall objective is to evaluate the impact of using the female-specific 99th percentile cut point. So when you make the diagnosis of MI, we have agreed that if your value for troponin is over the 99th percentile, that is consistent with other things of a diagnosis of myocardial infarction. However, with high sensitivity cardiac troponin, we now understand there's not just one cut point. The cut points vary by sex, and I'll show that to you in a minute. So we want to see if we started adopting the sex-specific cut point for females, would that improve our diagnosis, therefore our treatment, and therefore our outcomes. And this is a burning issue because women have been underdiagnosed now for decades. So it is an important issue. So again, the audience is women presenting to the emergency department with chest pain and or other symptoms consistent with myocardial ischemia. So the rationale is, compared to men, women with acute coronary syndrome are much more likely to die, both short-term in hospital and longer term, compared to similar aged men. And this is particularly profound in the women under 55. As a matter of fact, by the time we get to our 80s and 85, women seem to do better than men. But certainly for those under 55, women have much worse short and long-term outcomes. They're much less likely to be diagnosed as myocardial infarction. Some of that is they present differently. Remember the little vignette with Esther presenting with dyspnea. That is an atypical symptom, unfortunate terminology, I'm afraid. But women, many of them will present with chest pain, but many more present with dyspnea, jaw pain, not the classic crushing retrosternal pain that we see in all the Hollywood movies with a man. So yes, women will have chest pain. They don't describe it the same way as men. They may describe it as discomfort. They may describe it as dyspnea, trouble breathing, etc. So all of this contributes to the fact that women tend to be underdiagnosed for MI. The other unfortunate thing, and this has not changed in the last 20 years, even if they do get the appropriate diagnosis, they're less likely to be referred to the cath lab. Remember, cardiac catheterization helps us determine if you have a blockage. They're less likely to be referred to a cardiologist. And even more disturbing, when they're discharged from hospital, we know that there are 4 classes of medications that you should be on unless you have a contraindication. Women are much less likely to be put on those evidence-based medications. And again, this has not changed over 20 years. So huge amount of work to do. So the rationale for CodeMi is that with cardiac troponin, the high sensitivity version, which picks up much lower levels with much greater accuracy, the female-specific 99th percentile is actually much, much lower than it is in men. And we have, for decades now, used not quite so sensitive troponins that had a single cut point. It didn't matter if you were male or female, that was the cut point. Now that we have high sensitivity, we do recognize women have lower levels. Even given for the size of the infarct, so the size of the heart damage, they will still produce less cardiac troponin. And we wonder if failing to take this difference into account is contributing to the underdiagnosis of women, and then, of course, the undertreatment and their worse outcomes. So again, just to emphasize, biomarkers, so the cardiac troponin is a biomarker, is only part of the picture. Physicians integrate information on your presenting symptoms. They also look at your ECG, so if they see an ST elevation, then you have an ST elevation MI. If you don't, it could be an NSTEMI. So this is all incorporated, but the biomarker is a critically important piece of making that diagnosis. So let me show you the difference here. So if you look at the outer window here, the black bars, this is how we have traditionally looked at the distribution of cardiac troponins. Now, what is done is you take a healthy population, you draw blood, you measure cardiac troponin in everybody, and then you plot out their values. And then by agreement, at the 99th percentile, this inverted triangle here, which has got 48 written above it, that is the 99th percentile. And so we agree if you're above that, that's abnormal, consistent with a myocardial infarct. But you have to pay attention to sex. So let me just blow up that inner bar so you can see it a little bit better. Now we've broken out females in gray, males in white, and what I want to draw your attention to is here at 33, that's the 99th percentile for female. Here at 55, that's the 99th percentile for males. And what do? We ignore it and we use 48. So the women here, and I've used this horizontal bar, they would be deemed to be normal, and yet they're well above their 99th percentile. So just to illustrate the importance of taking that into account. Just for your information, these are the 4 assays that are currently approved in Canada. And so for each one, I'm showing you the overall cut point when you ignore whether you're male and female, and then the female specific and the male specific, and you can see consistently across all assays, the female cut point is always lower than the males, and of course, it is lower than the overall cut point as well. Does it matter? And I think that's a fair question. So this was a study done by colleagues in Edinburgh in Scotland, and they actually tried to see if I got the measurement and used a sex-specific cut point but did not yet share that information with the doctors, what would happen to people's outcomes? And that's what this diagram actually shows you. So irrespective of using a sex-specific cut point, the blue line is the women who had no MI. So whether you use the overall or you use the sex-specific, by both measures, you did not have an MI. So you're not surprised to see that over almost 3 years here, their outcomes are pretty good. I mean, no one is perfect, but basically they have a very good outcome. Now, the red dotted line here is using the old-fashioned single cut point, and not surprisingly, these women had an MI, and so their chances of death or having another MI, of course, is much worse. So you can see it looks like 25% have an event over 3 years. But what's really important here, look at the green line. It essentially mirrors that red line. These are the women that were missed, for lack of a better word, because the sex-specific cut point was not used. So this shows you those women in that window that I illustrated before truly have an MI, and their outcomes mirror those who got the official diagnosis of MI. So really, this CodeMi trial is a call to action. So despite the evidence, despite the guidelines. As a matter of fact, the International Federation for Clinical Chemists, the 4th International Definition of MI, all recommend using sex-specific cut points. That has not been adopted. But also, in fairness, there is no evidence other than that suggestion from the trial in Edinburgh that it actually makes a difference. So we really want to test that. We want to say we've got, matter of fact, we have 30 hospitals now across Canada in 8 provinces. They're all using high sensitivity troponin, one of those 4 assays that I've shown you. And we're going to move them from the overall to the sex-specific, and then we're going to be able to document whether it actually does make a difference. So the specific objectives, we're going to see whether changing the entire hospital to the lower cut point for females will improve the diagnosis and therefore the therapeutic strategy. Whether it will, therefore, if you treat them properly, lead to a better prognosis. And our composite endpoint here is all-cause death, non-fatal MI, incident heart failure, and emergent or urgent coronary revasc at 30 days and at 1 year. And then we also want to do a cost-effectiveness study, or a health economic analysis, if you will, because you can imagine while we want to appropriately diagnose women, we don't want to diagnose a whole bunch of women that actually don't have MI and therefore drive up the healthcare costs. So embedded in our study is a health economic analysis as well. Now, what is unique about this study, and I think you'll appreciate why we had to do it this way, is it's a stepped wedge cluster randomized trial. So instead of randomizing patients, we are randomizing the timing of the switch to the sex-specific cut point by hospital. And I think you can appreciate why we have to use clusters. Can you imagine the chaos in an emergency department if you tried to randomize patients? You know, the doctor has to remember, okay, now this person gets this cut point, now this person gets this cut point. It would be absolute chaos. So the study has to actually change the performance or the process at the entire hospital. So the unit of randomization now is the hospital, not the patient. So they get 6 weeks of notice that we're going to make the change, and then everything in their system changes to reflect the lower cut point in the females. So the lab report changes, all of the comments that go with the lab report, everything changes at the same time, and the whole hospital behaves the same way. We chose a stepped wedge because I think you might be able to appreciate, given that the International Federation for Clinical Chemists and the 4th International Definition of MI are all recommending sex-specific, you can imagine probably people wouldn't want to join a trial if for 3 years they were going to use the old way of doing things. The beauty of the stepped wedge design is you may not know when you make the switch, but you will eventually make the switch. So by the end of the trial, every single hospital will be using the sex-specific cut point. And we think that's much more attractive to people because they are aware of these, recommended guidelines. So they do want to make the change. I think it would have been hard to enroll 30 hospitals if we said, for the next 3 years, we want you to ignore this and just business as usual. So this is a diagram that shows you what it looks like. So during the control period, all of our 30 hospitals are using the overall cut point. And then we have 5 separate steps where clusters of hospitals will be introduced to the sex-specific cut point. And by the time we get here, this is our 5th step, you can see from this dark area, every single hospital is now in the intervention period. And then we follow everybody up for at least a year because our main endpoint is at 1 year. The other thing that is unique, because as I've said, we're randomizing hospitals, we do not need to screen, enroll, or consent individual patients. So the hospital is giving approval for changing their processes at the hospital level. So you can imagine for the individual hospital, and especially ED docs, this is a very easy trial to implement. They don't need to screen or consent patients or get them to sign forms, etc. So, and the reason for that is the patient is not undergoing any research-specific procedures. The whole hospital has agreed we're going to adopt an already recommended cut point. So ethically, this has not been an issue. And the other unique feature about our study, which again I think makes it much easier for the sites, is we're not asking for any de novo data collection. Those of you who run trials are probably aware of case report forms that are pages and pages long. We have to fill in all sorts of information about the patient. We're actually using administrative data for the entire study. There is no data collection by the hospital or by the individual physicians. We're using data that they are routinely collecting to do the entire study, including the follow-up. Just a quick diagram. So we have 3 hospitals in BC, 3 hospitals in Alberta. We have 2 in Edmonton, 1 in Calgary, 2 in Saskatchewan. We have St. Boniface in Winnipeg. We have 12 hospitals in Ontario. Of course, it has the biggest population. We have, I think, 5 hospitals in Quebec. We also have 1 hospital in New Brunswick and 1 hospital in Nova Scotia. And we're delighted, actually, because it gives us really a pan-Canadian picture of how this is going to play out. So how do we define our study population? I've already alluded to the fact that we use administrative data. So we use a couple of things. So every emergency department in Canada uses a CEDAS code. That's been well validated. It's for their presenting symptoms, and they have certain codes. I just showed you 003, which is cardiac chest pain. We're also including the code for dyspnea, and actually we're also including the code for non-cardiac, again because we're worried that the physicians diagnose this pain inappropriately. The exclusions really are patients that are too young to truly probably have had a valid MI. If you don't have a valid personal health number, or whatever the provinces call it, Alberta calls it unique health number, so we need that. I think you can imagine if we're going to put together this administrative data, we need a unique identifier that allows us to put together all the data that relates to that particular patient. If you're not a resident in the same province or from out of the country, of course, we would exclude you. And then we're going to exclude anyone who had a chest pain visit in the previous year to try and create an incident cohort. So for the efficacy endpoint, I've alluded to this before, it's a composite endpoint. So within a year, did you die? Did you have another heart attack, another MI? Did you have incident heart failure? The reason we make a big deal about incident heart failure, remember I said we would include dyspnea as one of the presenting symptoms. Well, people with heart failure do present with dyspnea, and so we don't want to enrich our sample with heart failure patients who, as you know, re-present to hospital quite frequently and drive our numbers up. That would not be appropriate. However, if that woman truly had a myocardial infarction and it was missed, the chances that she would present for the first time with heart failure is very high. So we think that is an appropriate endpoint. And then we also wanted to include urgent or emergent revascularization. The reason we put urgent and emergent, if you have gone into the cath lab, they did found a blockage, they did put a stent in, and then they saw something else they didn't want to deal with right away, they call that staged. We don't want to count those. That was always their intent that they would do that. But those patients do not come back into hospital with a coding of urgent emergent. They would come in with elective because it was always planned. So again, trying to make sure our endpoint really reflects what we're interested in. We also did a safety endpoint, and that is from the Bleeding Academic Research Consortium. You can use administrative codes actually to define life-threatening or major bleeding. So we include that as our safety endpoint. So our main statistical analysis is really the one-year MACE rate, so that composite endpoint, between the control phase and the intervention phase for each individual hospital, and again for women in that cut point window. So above the female specific, but below the overall, because that's where the difference is going to happen. And so the study is actually powered to do that. How do we power it? We were very fortunate. We got some data from hospitals in Ontario. Ontario actually has a provincial lab information system, so we were able to put together the troponin values with the presenting codes in the emergency department, tease out that population of interest, and then look at their event rates over a year, which is a gift to someone trying to power a study. And we assumed a 20% one-year MACE rate. This is based on the Ontario data. We need to recruit at least 116 women in that cut point window per site per 6 months. And again, that is entirely doable. We had numbers between 2 and 300 based on the Ontario data, and classically we're using the two-sided alpha of 0.05. With what we know about the 30 sites and with these assumptions, we have actually 84% power to detect a 15% relative risk reduction, which, by the way, translates to a 2.1% absolute risk reduction. So we think those are big enough differences that if we show that we're right, practice will change, and we are adequately powered to detect these differences. So I've alluded a little bit to the linkage process. It is quite complicated, but just to give you a high-level picture, we first define the cohort using the emergency department data in a database that's called NACRS, National Ambulatory Care Database Reporting System Database. So this includes those CETUS codes, those presenting symptom codes, and that then is merged in each hospital with their lab data. So given that someone presented with those codes within 24 hours, did they have any troponin testing? Whoops, they are part of the cohort. And then we have a partnership with CIHI, the Canadian Institutes for Health Information. For those of you who may not know, every hospital sends their data to CIHI. It happens to be in Toronto, including Quebec now as well. And they will then take the data, so that cohort from every hospital, and link it to the discharge abstract database to give us our outcomes. So all of that data is in there. For interest and for costing, we're also looking at physician visits, and we're also looking at vital statistics. The reason that's important is not everybody dies in hospital, so we cannot rely on the deaths in hospital. Vital statistics will give us deaths irrespective of where they actually occurred. And then it's going to be stored on a secure server. Once it's all amalgamated and linkable, it'll be de-identified for security reasons. They will. Good question. We don't trust it, however, especially for cardiovascular death. That sounds terrible. If it was a cancer death, I'd have complete certainty. Cardiovascular death, we've been informed reliably that if they can't figure out what else went wrong, well, the heart stopped, so it's a cardiovascular death. So it is likely to be overcoded, and so we thought it was safer to take all-cause mortality. But it will give you cause of death, yeah. So a little bit of all the things that the hospitals need to go through. You know, as I told you, they don't need to screen, they don't need to consent, they don't need to collect data, they don't need to follow up, but they do have some work to do. So I said 6 months before, we have to have them on high sensitivity troponin, completely comfortable using that assay. It's a big switch from the old one in order to be eligible to be switched. We have to have more than one department engaged in this, and I think you can appreciate we want the emergency docs on board, we want cardiology on board, and we need the lab on board. And so every hospital, we have leads from each of those departments who are in agreement that they're going to participate in the trial and what their respective roles are. Ethics approval, most of the sites now have ethics approval. We're working with UBC to get the final contracts done. As you can appreciate, we do have to have some training. Yes, the lab report will come out with, you know, this is the new cut point because you have a female, but we also have some very short education messages to alert them to, you know, this is above the female cut point. You need to incorporate this into your diagnostic workup and decide appropriately what to do. We keep those messages very short, of course. We have a slide deck online that they can access, and we're trying to work with every site to customize the education so it's relevant to each particular hospital. And of course, we're working with the IT department in every hospital because, of course, the lab reporting has to change at the time that we actually make that switch. Just to give you a sense of the number of people that are involved in this study, I'm delighted that my chair is Nicholas Mills. He is actually from Edinburgh, and he ran that trial that study that I first showed you. He also ran the similar trial in Scotland. Now, I have to be honest, he did not find a difference when they used the lower cut point. But when I came to him about my study, he said, Karin, you have to do your study. As for all of us, after you do your study, you go, why didn't I try this? His point was we moved every site from regular troponin to sex-specific high sensitivity, so that's a radical change with no education messages. Our study is different. Everyone is already on high sensitivity, so they've made that transition. They're comfortable. Now we're doing just one thing. We're lowering the female cut point and we're bombarding you with education messages. He thinks in retrospect, if he had done that, he would have had the power to see a difference. By the way, it went in the right direction. It just wasn't powered. And again, remember, from regular to high sensitivity sex specific with no education messages was a huge leap for most sites. So it was considered a negative trial. As you can see, actually I'm delighted Jim Christensen is my co-PI. Those of you who may not know him, he's an ED doc at VGH. He runs the emergency department actually for UBC, so it's great to have him on board. A really powerful team. We have 2 patient partners who have been instrumental in helping us with the education messages. Every province has their own provincial lead, and then as you can see at the bottom of the diagram, as I mentioned, in every hospital, there's an emergency department lead, a cardiology lead, and a lab lead who helps us at that particular site. We have a data monitoring committee. That's going to be a little challenging. It's not the classic data monitoring, I think, as you can appreciate, because we only get our data at the very end. But again, remember, we're not doing an intervention that is untested here, so it's unlikely to cause any problems. We have some experts on knowledge translation, and I have a great team that helps me with my education messages as well. So with that, I hope I haven't run out of time. Oh, no, I've got lots of time. No, I don't. Sorry. Just if you are interested, we have not been able to get VGH on board. I don't know if anybody here works at Vancouver General, but we would love to get them on board. They actually aren't using high sensitivity cardiac troponin yet, which is a little disappointing for us. We're hoping, because the trial will take until 2023 to complete, that they might at least start high sensitivity and still be able to get into the study. But St. Paul's is on board here, Royal Jubilee on the island, and we also have Fraser Health. As a matter of fact, Royal Columbia and the entire Fraser Health, it looks like the entire unit is going to come on board. But I'd love to have VGH. So if anyone has any influence at VGH, yeah, please let me know. It would be nice to have one of our leading teaching hospitals engaged in this particular study. So with that, I'd like to end and leave time for questions, comments. Anyways, thank you so much for your attention. I appreciate it. Yes, please. Yeah. Yeah. Right.
And I'm wondering about if in the patient demographics you might be able to look at the equity issues and some of the social determinants of health that might impact not only women coming in, but also maybe not getting the same level of respectful care.
Yeah, that is so important. Given that we're using administrative data, that's a little challenging, because remember, there's no de novo data collection. So some of those important but softer endpoints I won't be able to collect. We do sometimes, probably other people in the audience as well, we try to use the patient's postal code as a proxy for income, for socioeconomic status. That's a bit of a blunt instrument, but off the top of my head, Susan, I think at the moment the way the study is designed, that's probably the best that I can do. It's a really important question, but honestly, it would be very hard to tease that out. Yeah.
Another study.
Yeah, exactly. Yeah.
Did I not turn it on?
Oh, it did work. There we go.
I know, I think you have a really fantastic paper out looking at differences between sex and gender.
Oh, right.
And CIHR doesn't just ask about sex, but asks about gender. So two questions. I think it seems like it's more of a sex focus rather than a gendered focus.
It is.
Wondering if there's any possibility to look at gender, but then also, how did you get CIHR funding without considering gender? How did you do that? I'm just going to take notes while you talk.
Yeah, no, very good point. And actually, that's an issue that I think people get confused by. At a minimum, CIHR wants you to incorporate sex at a minimum, and I've done that in this study. It would be wonderful if you could also incorporate gender, but in many studies that is much more challenging, including in my study.
Well, I mean, I've gotten a lot of respect from CIHR.
Have you? Yeah. Right. Well, I guess if they think from your study design you should be able to incorporate gender, then I think you'll get some pushback. again, kind of like with the issue just raised by Susan, how am I going to measure gender given that I'm using administrative data? And that's really a challenge here. I wish we could, because as you probably know from the paper that you saw, I've had the privilege of working with Colleen Norris in Alberta, Louise Pilote in Quebec. They've come up actually with a gender index, so we actually now have a tool. I don't know if you know, it's 75 questions. We're trying, yeah, you've seen it, yeah. We are trying to boil that down to something that is more practical. I don't think too many RCTs would allow you to, 75 questions. But, it's a work in progress, and it's going in the right direction. So it's really, I think I got away with it with CIHR because I am using administrative data, and therefore I just really can't do it. Not to say it isn't important, but in this design I cannot do it.
Okay, and we have a question from our listeners at home.
Okay.
When the HS troponin is higher than 33 in women, does it always mean that small vessel vasospasms is the issue?
Good question. No, it doesn't always mean that. It does mean that that female has myocardial injury, but it could actually still be due to the epicardial vessels. It does not need to be microvascular disease. So it is telling you myocardial injury. It is not helping you tease whether it's the big epicardial vessels or the microvasculature.
Did I just turn it on mute?
There it goes. Yeah.
Helen Tremler. I get so excited by your study. I think it's brilliant. But same with all of us trying to write these grants where we're using health administrative data. What about other confounders that may be relevant to your study and also, say, relevant to mine, like smoking, body mass index? Is that a problem for you guys? Can you get any of that data in any of the provinces? I don't know what other confounders are relevant for you. I mean, we'd always love diet and whatever, but maybe smoking and BMI is the most relevant.
Yeah, and as you probably know, Helen, smoking is poorly coded in administrative data. We never use administrative data for smoking. If there's a code there, but it's useless. BMI, I probably could get at that, Helen, probably from the lab, I'm guessing. But the argument that we're using in the stepped wedge randomized controlled trial is we have no compelling evidence that in the 6 months before you switch and then the 6 months after you've switched, that your women will be systematically different between those two periods within the same hospital. And that's what we're relying on, because you're absolutely right. There's a whole bunch of confounders I cannot measure, but I think our assumption for this study design probably holds. Yeah.
Any other questions in the room? Okay, so I have kind of just a general female-male looking at cardiovascular disease from a family history point of view.
Yeah.
If the men in your family are the ones having heart attacks and you're a woman, what is your likelihood genetically? Do we know that yet?
Oh.
Has anyone considered that?
Yeah, good question. And again, as you probably appreciate, it's not just genetics.
Right.
I think if the men in my family are all having heart disease, I would say, okay, there's probably a genetic component there, but is there an environmental component as well? For that reason alone, I would be worried as a female. Absolutely. Yeah. Okay. I can't answer the genetics. I'm sorry. I'm sure.
No, I mean, I'm sure we're getting there.
Yeah.
I don't know when I hadn't read. This is not my area.
No, that's quite right. And genetics is not my area either. But I mean, cardiovascular disease, absolutely, there is an important genetic component, but so much of it is environmental. And to me, that is the equally important aspect. So if the men in your family are having heart attacks, it may be genetic, but it may also be the lifestyle of that family. Is it your diet, your physical activity?
Which would affect women as well.
Exactly. Yeah.
Any other questions from the floor or in the room?
Mm-hmm.
I'll hate me because it's a comment more than a question.
Sure.
But it just struck me because you talked about, obviously it's underdiagnosed, acute coronary syndrome in females, and also they present with atypical symptoms, which I think you even said something about it. And the same thing happens with major depressive disorder. We had Thalia Field talking about the same atypical symptoms in females with stroke.
Yeah.
And to me, that just, is it atypical because we've defined it in terms of male symptoms and male presentation? So how is it, especially if you're giving numbers like 55% or, you know, for depression, it's twice more likely. And obviously it's not atypical because it's the more typical presentation. But, there's no question there other than like, how do we, will we ever get to changing that? And is it recognized at least in, I always hear that for cardiovascular disease and health, you guys are way further ahead for sex and gender.
Yes, that's kind of you. I'm not so sure we are. But you know what? You're absolutely right. The term, and I think I said the unfortunate term atypical, and I do mean that sincerely, is based on you don't look like a man. Well, no kidding, right? So that, sadly, it is where that term came from. I sincerely hope over time that will go away. Because, you know, there's been so much misinformation. Unfortunately, even Oprah Winfrey jumped in on this and unfortunately made a statement, women's symptoms are completely different from men. I know she was trying to redress the balance, but I think she did some harm there too. It is not completely different from men, especially in young women. 80% of young women will have chest pain, but women have way more symptoms than just chest pain. So a couple of things, this unfortunate term of atypical needs to disappear. A lot of women have dyspnea. A lot of women have jaw pain. They describe their chest pain as discomfort rather than crushing pain. You know, that needs to be accepted as normal for women, right? So stop calling it atypical. But also don't mislead women into thinking that they don't have chest pain. They do, right? So there's so much work that still has to be done there amongst the lay public and sadly amongst professionals as well. Yeah.
I have one other question, comment, because I'm fascinated by how you've set this study up. My world of lactation and the baby-friendly initiative, and how might we implement something like that doesn't have the kind of codes to recognize it into a hospital system. But any suggestions for other more health promotive and preventive? Because ultimately, by catching these women with those lower levels, we will hopefully prevent worse things. Any other areas where this might be applicable?
Yeah, I mean, good question. I mean, I think, you know, one area where I personally would like to see people do more work is, as this audience I'm sure knows, in women that have preeclampsia during their pregnancies, in women that have gestational diabetes during their pregnancy. These are major risk factors for women for developing cardiovascular disease later. These are coded in administrative data. I would really like to see that used more. Not only that, I would argue that every physician you know, who has a visit with a female patient should not just be recording blood pressure and cholesterol, but should actually be asking during any of your pregnancies, did you have a preeclampsia? Did you have gestational diabetes? It should become part of their medical record. So on two fronts, absolutely, those things are coded in administrative data. We could look at that much better than we do, but I would argue it needs to actually be collected in a physician visit as a critical component of working up the female patient, because we do understand what an important risk factor that is.
I think your nurse practitioners will catch it.
I think they will, if anyone, yeah.
On the genetics point, there is actually a hereditary link with preeclampsia.
Is there a hereditary
link? It's different from the later stage hypertension that you see, but the true preeclampsia ladies, their sisters have more than double the rate
of
preeclampsia in their, comparing first pregnancy to first pregnancy.
Right. Oh, even more of a strong argument for collecting that information. Wow. Yeah. Thank you. I didn't know that.
And I think...
Okay. Well, thank you so much. Wonderful. Oh, thank you. Thank you. Appreciate it.